Welcome to This Explainer. Today, we're diving into something that is absolutely crucial: navigating the incredibly complex, delicate balancing act of assessing and treating chronic pain in older adults. If you've ever watched a loved one struggle, or maybe you're dealing with it yourself, you know exactly how frustrating it can be. But by leaning into the latest clinical pharmacology data, we're going to unpack exactly what's happening in the aging body. We'll break down the real science of why this happens, how clinicians act as detectives to accurately find the source, and exactly what targeted treatments actually move the needle. Okay, let's take a quick look at our roadmap. We'll be covering 1. The aging pain myth, 2. Why pain changes with age, 3. The assessment challenge, 4. The medication balancing act, 5. Beyond the pill, and finally, 6. Targeted interventions. Let's get right to it. Section 1. The aging pain myth. Let's look at the truth about aging and pain. We really have to start by confronting a pervasive and honestly dangerous assumption. A staggering 60% of people aged 65 and above suffer from chronic pain. To put that into perspective, that's well over half of the older adult population. It's a massive public health issue that constantly contributes to reduced mobility and a total loss of independence. But just because it's common does not mean it's normal. The psychology behind that statistic is kind of alarming. Because pain is just so prevalent, a lot of elderly patients assume it's simply an inevitable, untreatable consequence of aging. They basically think, hey, I'm getting older, so I'm supposed to hurt. And this false assumption literally stops patients from getting the care they desperately need. But the medical reality, chronic pain is a distinct pathological process. Things like osteoarthritis, postherpetic neuralgia, or diabetic neuropathy. It is definitely not just normal aging. Moving on to Section 2, why pain changes with age. We'll look at both the peripheral and central nervous systems. To really understand why pain feels different as we age, we have to look under the hood at our changing physiology. Out in the periphery, the nerves in your limbs, we actually see higher firing rates in C fibers. And it takes significantly longer for injured nerves to recover. This means peripheral nerves literally become more sensitive to inflammation. Meanwhile, up in the central nervous system, the brain and spinal cord, there's a decrease in neurotransmitters like serotonin and dopamine, alongside an upregulation of NMDA receptors. To put it simply, the brain loses some of its natural built-in ability to put the brakes on pain signals. And so, this creates a really dangerous paradox. Because of those combined changes, older adults might not actually detect mild pain stimuli as easily, like a small cut or a slight burn. But once that pain signal breaks through, they are far more vulnerable to severe, long-lasting central sensitization. Essentially, the pain stays longer and hits way harder. Which brings us to Section 3, the assessment challenge, finding the source of the pain. Now, obviously, before we can treat this heightened pain, we have to accurately find and measure it. In younger folks, you just ask, hey, where does it hurt? But in the geriatric population, doctors frequently have to act as clinical detectives. They're often navigating cognitive impairments, progressive dementia, or aphasia, which is the loss of ability to understand or express speech. It requires a really highly individualized approach to figure out what the patient is truly experiencing when they can't just tell you. Because of this, clinicians have to shift their strategies based entirely on the patient. For cognitively intact patients, they can absolutely rely on self-reporting tools, like the classic 0 to 10 numeric rating scale or the Pain Detect questionnaire for nerve pain. But when advanced dementia is in the picture, verbal communication is out the window. Clinicians have to become observers. They shift to tools like the Pain Ad scale, watching breathing patterns, listening for vocalizations, and studying facial expressions and body language just to score the severity of the pain. Section 4, the Medication Balancing Act. Weighing the risks and rewards. Once we've accurately assessed the pain, we enter, actually, it's more like a medication minefield. In older adults, every single pharmacological tool comes with a serious warning label, mostly guided by what's known as the Beers criteria. Traditional NSAIDs, like ibuprofen, they carry high gastrointestinal bleeding risks and can exacerbate heart failure and chronic kidney disease. Tricyclic antidepressants, or TCAs, sometimes used for nerve pain, generally need to be avoided completely because they cause dangerous anticholinergic side effects, things like urinary retention and acute confusion in frail patients. Even acetaminophen, the standard go-to, requires a 30 to 50% dose reduction if there's underlying liver disease. And gabapentinoids? Sure, they improve nerve pain, but they drastically increase the risk of dizziness and severe falls. It is a constant, delicate game of weighing risks versus rewards. And this balancing act gets especially precarious when we talk about opioids. When pain is incredibly severe and opioids are absolutely necessary, you have to remember that not all are created equal for older bodies. Clinicians will often opt for buprenorphine. Why? Because it's processed in the liver and has a built-in sealing effect on respiratory depression, making it much, much safer. On the flip side, morphine must be strictly avoided in patients with renal dysfunction. Since older adults often have declining kidney function, morphine's metabolites can't be cleared properly, and that leads to a really toxic neurotoxic buildup in the body.
No, thank you.
Section 5. Beyond the pill. Taking a holistic wellness approach. Because of these immense systemic medication risks we just talked about, we really have to lean heavily into non-pharmacological tools. It's a sequential, holistic approach. Step 1 is always assessing the patient's unique physical and cognitive limits. Step 2 leans into physical therapy. Now, this isn't just about some light stretching. It's about structured movement and strength training to restore actual independence, which lessens the need for painkillers in the first place. Finally, Step 3 utilizes cognitive behavioral therapy, or CBT. Remember, pain is biopsychosocial. CBT helps conquer the psychological toll, the depression, and that catastrophic thinking that so often acts like a megaphone, amplifying the physical feeling of pain.
Section 6. Targeted Interventions. Looking at precision therapies.
So what happens when conservative measures and systemic medications simply aren't cutting it? That is when we turn to highly precise tools like radiofrequency ablation, or RFA. It's a minimally invasive procedure where doctors use a specialized electrode guided by imaging. They use alternating currents to generate heat and essentially create a small thermal lesion right on a sensory nerve. This physically disrupts and just turns off the pain signals coming from an arthritic facet joint in the spine. It's a real game changer, offering patients anywhere from 6 to 12 months of relief, entirely bypassing those dangerous systemic side effects of opioid drugs. Another totally fascinating intervention is spinal cord stimulation. Now, this is usually reserved for severe, intractable nerve pain that just refuses to respond to anything else. Clinicians implant epidural electrodes that deliver low-voltage electrical currents directly to the spinal cord. It's literally like a pacemaker for the spine. By delivering these targeted currents, it actively masks and disrupts pain signals before they ever have the chance to reach the brain. Ultimately, whether it's an RFA, a spinal cord stimulator, or an epidural steroid injection, the overarching goal isn't just about turning off pain for a few hours. It's about giving older adults months or even years of long-term relief. But more importantly, it's about improved function. It's about extending their independence, allowing them to walk, sleep, and just participate in life without being tethered to a pill bottle. We've clearly established through the science today that chronic pain isn't just an inevitable part of getting older. It is a distinct condition that requires precise, highly individualized treatment. So, armed with this knowledge, what steps will you take today to advocate for the balanced, targeted care that you and your family truly deserve? Thank you so much for joining me for this explainer, and I really hope this empowers you to seek out better, more functional outcomes. Catch you next time.